the sort of three sort of key things which we were sort of have been, really turning our minds to are, we actually have weapons, not perfect weapons, and we need some more weapons. But when we have our weapons, how do we ensure equity of access? What are the approaches that we need to be introducing and thinking about introducing to ensure we have that equity of access? And what are the barriers that we need to overcome, and issues, were brought up of geography, gender, stigma, the role of peers and the like, and non-siloed approaches. So first of all, if there's people in the audience, feel free to come down and ask questions. But can I ask our panel members, and I'll start up far left, what do we need, what would you think needs to be our priorities if we're going to say we've got, as I said, some good weapons, we need some more, but how, even when we get those new good weapons as well, are we going to actually make this happen?
Thanks. One of the important things which I did not cite is political will. Without the political will, it's not going to move. The Australians have led the way here because the government believes that this is doable. The Egyptians has been doing it because they have a sense of responsibility of treating people, not only because of because of a treatment that is inexpensive, but because they also have an obligation to do that, feeling of treating the people. That's one of the very important things. I think political will have to be there. We have to find the money and the mechanism to treat the people that are needing the treatment. The other thing very important, which I think is at some point we have to talk about, is task sharing. Especially in the case of viral hepatitis, it should not remain as something within the specialist fraternity. For example, I was talking about India, where all these medications are there, and they have around 2,500 approximately gastro or hepatology doctors, of which 650 have ever treated hepatitis C. And not everybody has used DAAs at this point. So you cannot treat, and they have around 8 million viremic cases. So you cannot think about treating 8 million people with a physician base of 250 people. So we have to talk about task sharing and taking this forward to other people, the GPs. We have seen good posters and data that are coming out from the US, where they have compared GPs and RMPs and registered nurses along with specialists on the same patient population, and everybody has fared well. So task sharing is also going to be an important factor. But beyond that, the political will, where the government would feel that this is something where that they should be taking forward, is something which is important.
Anybody else got a comment or on that point?
I'll just talking to, with Indonesia, there's 25 million people with hepatitis B in Indonesia, and there's 165 specialists in Indonesia, mostly on Sumatra. And the kind of impact of their national strategy is talking about kind of stopping the morbidity associated with hepatitis B, but they're not talking about any kind of alternative models of care to enable that to happen. One of the things for me in Australia is that we did get hepatitis, when hepatitis C treatments were made available, it changed from being prescribed by specialists to being prescribed in general practice, which essentially kind of opened up the field a lot. But it hasn't necessarily translated into... There are still issues in terms of healthcare access to general practice for people with hepatitis C. Some of it is around stigma and discrimination because it is implicit if you go to a GP and say that you want treatment for hepatitis C, that you have a history. And quite often still that there is not effective responses from GPs about that.
I mean, I know, say in Victoria we've got community-based and nurse-led models of care, and we're just about to start some work in Myanmar because I think this is a really major issue as to how do we move care out of the tertiary hospitals, not just in Australia but in anywhere, into community. In Myanmar, the same numbers. It's just like there's hundreds and I think there's millions of people to be treated for hepatitis C, and so we're just about to do a pilot on a paper check using the same model that we would use in Australia, where you don't have to see the specialist, but a community-based doctors allowed to do a paper check. I think this will be one of our enormous challenges as we roll out, and this is not just for hepatitis C. I mean, HIV has led the way, and I mean, I guess that would be my question, Brent, Edwina. I mean, I've got sort of thoughts on this. What are the learnings we can take? Because this is something that happened in HIV years ago around the world, as to what are those learnings that we can take from HIV to move treatment out of the tertiary systems into community?
I think the first thing, building on what Gitan is saying, political will is all well and good, but political parties change. Unless you have policy reform underpinning political will, unfortunately, when political leaders change, sometimes so does everything else, and everything goes out, baby goes out with the bathwater. But in terms of HIV, I think the thing that I see that's very different is that many programs and services in HIV from the very beginning were co-designed with community. Not for community, but with the community. And that meant harnessing the capacity of the affected community, the goodwill, the altruism of the community as well, which then led to a workforce development. So you ended up with a workforce that came from the community that was co-designing with you. I really would challenge the notion that, there's community rollout of work in HCV and hepatitis B. I mean, I'm not as familiar with Hep B, but I don't see it happening, really. I see a lot of stuff happening for people with hepatitis and not a lot of work happening with people. That's my criticism.
Yeah, I think the notion of nothing about me without me is the really succinct way of saying it. Is a great way of encapsulating how to progress any infection or disease to eradicate it or prevent it. It's very simple and it makes a lot of sense to people. And I think we have to just start to break down some of the barriers about who we think we are. I mean, in HIV, we have no cure for HIV. What do we really have to offer people? Where I'm a person who can give you some treatment, I certainly can't cure you. For a long time, I didn't even know that by treating you, I could prevent HIV infection. So you have to kind of all just get on a level playing field and work together and offer up what you know, because pounds to pence, you know a lot less. What you don't know is huge. And so to take people off the platform of being scientists, doctors, etc., and take away some of the hubris that can come with that and work with people and be prepared to be schooled and learn hard lessons from people who are actually living with these infections makes a huge difference conceptually. And I do actually think that doctors, researchers and scientists have to start becoming much less concerned and anxious about identifying themselves as activists. You can see it happening in the US at the moment with the new administration. Scientists are really beginning to understand that they have to mobilise, they have to get together and find common and shared aims, or things will be lost to them. And I think we should be unafraid of being activists.
Okay, well, this is a question for the two new activists on the bench, Heidi and Peter. Having sort of heard these conversations, what do you think needs to happen? You talked about the money that had been put towards HIV and vaccine and treatment, and the lack of money in viral hepatitis. I personally never liked that story because as a person who works both in HIV and viral hepatitis, it's like, as I say, I stand up in the morning and have an argument with myself about who should get the funding. I find it unhelpful. But what do you think are the lessons that we can learn from how HIV got that initial funding to get not their money, but money from other places to boost the cause in terms of cure and vaccines?
Yeah, and I certainly didn't mean to imply, I hope I didn't, that the money should not have been spent on HIV, because the hepatitis B treatments that we have now came out of the HIV field. It's the same antiretroviral therapies that work for HIV are working for hepatitis B. So that they would never have been discovered or developed if it wasn't for that huge impetus of research funds that went into the HIV sphere. So that's incredibly important to remember and acknowledge. But I think the time is now to increase funding for hepatitis B and hepatitis C research. You will not eliminate hepatitis C, as Heidi so eloquently said, without a vaccine. We have sort of reverse scenarios with both viruses. We have a preventative vaccine but no cure for hepatitis B, and we have the reverse for hepatitis C. We have cures for most people, if they can access them, but we don't have a preventative vaccine. So the challenge for globally is to sort of join those two paradigms together, if you like, so that we have a preventative vaccine and a cure for both viruses. And it's going to need billions of dollars of research. And touching on the political situation, I learnt last week in a teleconference with the United States that President Trump is planning to pull $1 billion out of the National Institutes of Health research budget. Billion, and that was going to the Capitol Hill last week for discussion, and I'm not sure whether I'm assuming it didn't get support, but that's the political mentality that we're dealing with at the moment. I'm at a liver conference in Amsterdam in a couple of weeks' time, and there's a pro-science march that I'm going to go on. So I think that's fantastic, right? March for science, because we've got to become activists. I mean, we can't sit in our little laboratories anymore. And I mean, we are all activists, whether we work with hepatitis, whether we live with it, whether we know somebody who works with it or lives with it. We should all be out there advocating all the time. So I don't know, I've waffled on a little bit, Margaret, but we need to increase that investment in hepatitis research without taking anything away from the HIV sphere, because that work still needs to be done. They don't have a cure. So they've had cure programs since 2010. These viruses are tricky. HIV was discovered in the 80s, but hepatitis B has been with us for 50,000 years. There's a lot we don't know about this virus. My chap's got his hand up, sorry.
I think there's a microphone that you can use, thank you.
John Moss from the University of Adelaide. You've just commented on the imperfections of the strategies we have available at the moment to deal with the hepatitis viruses. Would you comment on whether we should at this stage be developing social and therapeutic clinical strategies for dealing with drug-resistant strains, given the potential for the dynamics of the drug-resistant strains to be such that they could be a much greater problem as time goes on? You know, for example, in 2030, will we be looking at a lost opportunity when we had a window where we had very effective drugs for hepatitis C, not completely effective, and would we by then perhaps be mourning the emergence and spread of drug-resistant strains?
That's a good question. I might defer to Heidi for the Hep C, and then I'll talk briefly about the Hep B story.
Well, we know for hepatitis C that 54% of the isolates in the Los Alamos database for hepatitis C have drug-resistant mutations already, and that's before they've even seen treatment. So hepatitis C is an incredibly tolerant virus of mutations. So they already have one or more mutation in the protease protein and in the NS5A, which are two of the major targets for some of the therapies. So that's a huge concern, and I absolutely agree with you that we need to be doing very active surveillance of people who fail therapy and what happens to those people, and whether we can use other treatments with different combinations of drugs to perhaps treat those people, and don't just let them disappear into the ether, where they may be actually sources for ongoing transmission of those drug-resistant variants.
Yeah, I often go to conferences where people talk about resistance not being an issue. And it's not a major issue at the moment, but I think it's absolute hubris. And if we've learnt nothing from other bugs and history as a person who, you know, was brought up in the infectious diseases world and what's happened with antibiotics, it's naive to think that these bugs won't figure a way. So we've got to be doing this in a really clever way. That's to me, it's one of the great reasons why I think we do need vaccines. We need prevention and all of those things. We cannot just think we're going to go to... I personally think we can't think. As a great advocate of treatment for all, I don't think we can simply treat our way out of this or any of these diseases. I can see another...
Thank you.
There has been no failure. There's been no failure, I think, on the part of science or the medical services or anything like that at all. The failure has been at the political level. And in Australia, if it had not been for Neil Blewett, we wouldn't have had any of the money that we got in Australia, and we should never forget that.
And can I add, as a foreigner, absolutely there was political will, but there was very strong policy reform right behind it, which supported that ongoingly.
Stuart Kinner, MCRI, University of Melbourne. I just want to get back quickly to this notion of equity of access. And so inequity of access to these treatments is just an example of this inverse care law that we all know about. The people who most need the treatment, the most vulnerable, are the least likely to receive it. But it seems to me there's a unique silver lining on the cloud type of opportunity with infectious diseases, which is that unlike mental disorder and non-communicable chronic diseases, other people can get it. So I guess my question is, how do we utilise that unique opportunity in a way that doesn't further stigmatise already vulnerable and marginalised populations?
Good question. I'm going to hand this over to people from community to talk about the issue of stigma and then how one might deal with that.
I think the availability of a hepatitis C cure will fundamentally change the position of hepatitis C within the community and the position of people with hepatitis C within the community. That'll take time, but I think it will fundamentally change people's perspective of it because of the availability of a cure. I was kind of thinking, one of the opportunities is, within prison services, and particularly in Australia, which also has a higher proportion of Indigenous people within prison services, institutions, is the fact that we can provide treatment to people in prisons that we were never able to do so before, which is absolutely fantastic. The fact that the treatment is an 8 or a 12-week course, the fact that it's curative, the fact that it is there are few symptoms, fundamentally changes how it is that we kind of perceive things. But it will take time. And I am seeing changes that are occurring in terms of people's marginalisation from health services. The fact that you can kind of get a cure rather than be ashamed of your infection, I think changes things fundamentally.
I'd like to just also touch on the problems facing Indigenous Australia, particularly in the Northern Territory, where, as I said earlier in my talk, that rates of chronic hepatitis B are 5 and in some cases 25 times higher than those facing non-Indigenous Australians. And you don't want to have to go to prison to get access to. I know you weren't saying that, Jack, but it's if you are living in those remote communities, it's hard enough for people with access in non-Indigenous communities to get these treatments. And hepatitis B, as I've said, there's no cure. So this is lifelong therapy. So the challenges facing people living in those communities to get those life-saving therapies are enormous.
I think that, and I've postulated this in the past to people, what would happen if everyone living with hepatitis C simultaneously came out in all domains of their life? In their workplace, in their family lives, in their community settings. And I've thought the same thing about HIV in the past too, and I just can't help but think that things would radically change if that happened. If you knew the number of people in your social circles, in your family, in your church who are HIV positive or living with viral hepatitis, how fast things would change. We're talking about generational change before that's really going to occur, but we all have, I think, a role to play on creating enabling environments. And one of the things all of us can do is challenge the dialogue that happens, the side glances that are inappropriate, and call it out. The same way you would call out racism or misogyny, you call it out, and call it out every single time.
I'm Christine Connors from Darwin. I manage a number of Aboriginal primary healthcare services in remote communities. So I thought I might just update you in terms of what we're doing around hepatitis B, which is relatively recent, where we've been undertaking data linkage for our electronic health records, vaccination records and pathology testing, and then looking at the accuracy of that so that we can classify everyone's hepatitis status. And we're now looking at rolling that out across the top end, so with a focus on people with known chronic infection, getting them onto treatment, and then testing people who are unknown so that we can make sure that we've classified everyone correctly. And then what we're doing is actually linking everybody else who's not vaccinated into an ongoing sort of opportunistic, when they're coming in for a health check or a chronic disease check, then taking advantage of that to vaccinate them. So, that's still going to take time, obviously, but we've got a process in place, and I think the conversation earlier about how do you link this into routine primary care is really critical, because it is the only way to try and get a broader population approach. But I'm interested if the panel has got any other suggestions about where we should put in our focus.
Thank you. Was it Christine, was it? Sorry. Thanks, Christine. Actually, I've got a sort of question back for you and then I'll get back to the panel. Is, in terms of, because people are in an ACHIS, so an Aboriginal Community Controlled Health Service environment, but within the community itself, is there also stigma and discrimination against people with hepatitis B, and how is that being dealt with? I know in Victoria it is an issue within community, and I'm just thinking, how are you guys working with that and dealing with that?
At the moment, the reality is that the health literacy around hepatitis B is incredibly low. We're fortunate that our rates of HIV and hepatitis C infection are actually very low. Unfortunately, hepatitis B rates are very high, but very few people know about it. The story is actually very limited. We do have some resources that have been developed in local language that is starting to share those stories. And I suspect as more people are diagnosed and more people start accessing treatment, then we'll start to get more of those stories being spread. So at the moment, it's very, very limited.
I did a study in Torres Strait, which was looking at kind of the health service response to hepatitis B in the Torres Strait. One of the kind of things for me was that the health workforce wasn't necessarily terribly... there was a wide variety in the knowledge of people in the health workforce about hepatitis B. So for a lot of the time they had heard of hepatitis B 20 years ago when they were trained, but had not had, their education had not been improved since then. And there were a couple of kind of quite substantial kind of gaps in people's knowledge. One person talking about carriers, another one a nurse not realising the fact that treatment was available. So it needs to be, for me, it needs to occur within a context where the health workforce are educated and do know how to respond, and that there's actually an effective model of care available, so that if treatment is available or when monitoring is available, that is accessible. Another thing for me around Indigenous communities is that with Indigenous communities, there are so many comorbidities that are affecting Indigenous people. And with hepatitis B, it's such an asymptomatic illness most of the time, and it's kind of jostling for attention with diabetes, with kidney disease, with cardiovascular. It's really, really difficult to be able to kind of put any kind of story around how do you respond to hepatitis B. And I was at a community meeting last week, hepatitis B educators, and they were talking about maybe we can kind of frame hepatitis B as women's business. And I think we need to kind of think further about it, but it was just an interesting way of where it is that you could place hepatitis B, where you could enable a person with hepatitis B to respond effectively. And as women's business that occurs at birth, it kind of makes sense, but there needs to be much more discussion around that.
You're
Thanks.
right, the multiple comorbidities is a major challenge, and I think that would be true in many communities around the world. And it's competing demands not only for the patients, but also for the primary care clinicians.
Thank
I know
you.
of some
We're
wonderful...
going to, we're going to need to wind it up because there's overlapping sessions. We need to keep to time. Where were my instructions? I realised I didn't do the instructions of where the exits were, but you all know how to get out of here. Can I thank all of our speakers for really interesting presentations today? Thank you very much. Can I thank the people from the audience who contributed? Look, I think the take-home messages are, for me, it's not very often that we have real opportunities to eliminate diseases as public health threats. We'll use it because we have to talk about elimination as epidemiologists in the right way. But we do have those opportunities for hepatitis B, hepatitis C and HIV, and we need to be really working to take those. I think we have to be really thinking about equity, this must happen. We have weapons. We will have more weapons over the next few years. We have to make sure, how do we get them, that everybody has access? What do we need to do in terms of political will, agitation, marching for science? There are such things as facts, there are such things as evidence, and then we need to get them converted into quality policy as opposed to sort of the la-la, airy-fairy land. And I think I want to end with what sort of Brent had to say. Where you see stigma, and this is brought up constantly, we will not be successful at this unless people, the affected community, are prepared to come forward, as well as us sort of working to help them come forward. And so we need to call out stigma every time we see it, wherever we see it. Can I thank you all, and enjoy the rest of the conference.